Hello from the International Continence Society meeting in Abu Dhabi. We've kicked off a very active scientific program with a very important workshop which was led by Tony Kanai from Pittsburgh. I was a contributor as well. My name is Marcus Drake from London, and Tufan Tarcan, the General Secretary of the International Continence Society, also contributed. We had an active session, well attended, with good questions. So Tony, I feel this was a very successful workshop. Do you feel that we conveyed a strong message about the importance of the scientific studies in incontinence?
No, absolutely. I think what we did was to take and work from top down, talking with the bladder wall, talking with ureters, talking with the trigone, and ending with yourself dealing with the urethra. And I think that's reflected by the many questions that we had from the audience.
So scientifically, your contribution really focused on the physiology of the bladder itself?
Yeah, on the bladder wall, essentially.
Yeah, so what do you feel are the most important scientific points that people really, as they practice, should bear in mind about the science of the bladder?
Well, I think the most important features are its innervation, but that's quite complex. I mean, we talked about, for example, afferent innervation, we talked about sympathetic and parasympathetic, but there's so much more that we just couldn't go into in a talk of this duration. I mean, for example, ATPs, 5-HT, all of these are involved. So you have to restrict it, so we kept it to the basics in that regard. But I thought there was a robust, question and answer session where people brought up what they thought were very important questions, particularly I thought the urethra gathered, most of the questions.
So,
do you agree?
Tufan, you were focusing on the trigone. Yeah. I mean, I guess it's a bit artificial to separate the bladder wall from the trigone, but this is anatomically distinct. So what was the key trigone message?
Actually, the trigone has very unique features that separates it from the bladder dome in terms of especially smooth muscle physiology. And we had the chance today in the round table to discuss these. I mean, in summary, I can tell that the trigone is more excitable compared to the bladder dome, more irritable. This is due to its different embryonic origin, as well as that especially the superficial trigone is actually the continuation of the ureteric longitudinal muscle fibers. Just if you want me to summarize the main differences in terms of smooth muscle physiology, the spontaneous contractions are very common and very frequent in the trigone. And the contraction of the trigone smooth muscle is not affected, and especially these spontaneous contractions are not affected by the removal of the mucosa over the trigone, which is not the case in the bladder dome. And there are many gap junctions in the trigone, in contrast to the bladder dome, and there is a dual innervation. Both adrenergic and parasympathetic actually agonists increase the tone of the trigone. So these are the distinct features of the trigone. For many years, actually we have known that the trigone is more irritable, more excitable. However, we couldn't link it to the human disease, and still, unfortunately, we need more research in order to do that. The main diseases that we focused where trigonal pathologies could have an impact were, first of all, the overactive bladder syndrome, which sounds very good, very logical, and the other one was interstitial cystitis or bladder pain syndrome. About the bladder pain syndrome, it appears that not the trigone feels the pain, it is the bladder dome. And about overactive bladder syndrome, the discussion actually started or flamed with the use of botulinum neurotoxin, especially. We know today that injection of the trigone by botulinum neurotoxin does not cause reflux. This is something we know. But we still do not know whether only trigonal injections are better than the bladder dome injections or not. There are contradictory findings in the literature in this regard. So being more excitable, being more irritable actually does not necessarily lead to a pathophysiological link to to these conditions. But still, of course, trigone is a difficult place to study, really. I mean, you have to separate the trigone, which is not easy. So the main function of the trigone appears to be to establish or to maintain the reflux of the efflux of the urine through the ureterus, even during voiding, so that there's no obstruction, and to prevent reflux. And there is more space for research to be done to understand whether there is a link between the human disease and possible trigonal pathologies.
And whether the nociceptive function and the afferent function of the trigone is a big driver behind much of pathology, because I think, Tony, you believe the trigonal nerve supply is a big contributor.
Of course. But let me bring one thing. You mentioned the bladder wall, and we didn't have time, but I think it's worthwhile bringing it up here. I think one of the major functions of the bladder wall, people have talked about the urothelium for eons. And initially, years and years ago, they talked about it as being just essentially just a barrier function. That's clearly not the case. It's so much more than that. But what's been coming out lately is that the urothelium also functions as an osmoregulator. It regulates the osmolarity of the bladder, of the urine. And so, for example, and actually, it's not so much the urine, it regulates the osmolarity of the plasma. If that osmolarity changes, this can be compensated for by urothelial cells, bringing about passive reabsorption of water. And I think that's something we didn't have time for, and I think in future talks, that should be one of the things we dwell on. And I don't want to get into the topic of nocturia, that's a separate issue. But I think that's one of the key roles of the bladder that we just didn't have time to talk about.
Yeah, it's a big shame, because that is a topic that's very close to my heart.
No, I agree.
But you think it's a passive or secondary active? Because surely the osmolarity of urine is higher than plasma?
Well, they can be, typically, the osmolarity of urine is always lower, of the plasma is always less than urine, but they can be very close. But again, it's not there is some confusion. It's not osmosis, it's actually a passive diffusion, which is a form of osmosis. But it's just that, for example, recently it's been found that there is AVP in the bladder itself.
Yeah.
And so being there, that can be involved in resorption. Certainly it's through the hypothalamus. It's also been found in the renal collecting ducts. But it's a key thing in the bladder that this can be involved in regulating osmolarity and keeping the plasma. The plasma has to stay constant. That's true. It can't vary very much. And the great way to do that is through concentration of the urine.
Yeah, because it seems a shame if you've made dilute urine and then you have an insult like a blood loss or a dehydration and you're still storing that dilute urine, your body wants to get that back.
Sure.
I think they refer to that as allostasis as opposed to homeostasis.
Well, that sounds right.
But I think we did do some research to look at reabsorption in the pig bladder, an isolated pig bladder model. We did put vasopressin into the isolated pig systemic supply, and this is Bahari Vahabi and Brian Parsons did this. Didn't actually affect the reabsorption very well because we were looking for heavy water reabsorption and it didn't come through. So it's a complex model, but it would be very interesting really to develop a model that does demonstrate exactly that.
But I've got to admit, so there was an experiment that was suggested by Alan Wien that we actually conducted that experiment. And that was just simply to take a rodent and take one ureter, clip it, and put that into a valve, and let the other ureter dump into the bladder. And to measure what the actual amount that you found in the bladder. And clearly what we collected in that valve coming from one kidney was considerably more than what you found in the bladder, meaning that in the bladder there's reabsorption going on. So there's other ways to look at it. You can do it with isotopes. And I'm not trying to get off of the topic that we're on. I'm just trying to suggest that I think this is where these types of roundtables need to progress to. So I think this would be not focusing so much on nocturia, but just on the ability to reabsorb and how it can affect other factors.
That's a very interesting experiment, that one. It brings on nicely to Yoko's talk about the ureter. What was her key message? And
I should mention, I apologize, that the fourth person speaking here was Yoko Akito, and she did a very good job. She was talking about essentially the ureters and about the renal collecting ducts. And again, I think what we wanted to do in this roundtable was to essentially give sort of an overview of the function of the entire, of the bladder or lower urinary tract. And to try to do that in what amounts to say 40 minutes is very hard to do.
Very
so
hard.
I think we did a good job. Everybody did. I'm Tufan, yourself, and Yoko, in trying to keep this thing, to sort of link them together. But I think given the time frame, I think we covered what was feasible at the time.
So we also discussed the urethra, and one of the points that I made was about the difference between the sphincter structure of the female versus the male, and the female as being a more eccentric and the male being concentric, so that the male sphincter squeezes down and constricts as a circle, while the urethra of the female is kinked.
Sure.
And this was the joy of a round table discussion, was to have in the audience Paul Hodges stand up and say, but in the male I think there is an element of kinking going on, in the sense that you can see imaging where it's an uneven squeeze on the urethra, not concentric. Now, how did you feel about Tufan? Did you feel that made sense, to think of the male as perhaps two horseshoes opposing each other rather than in a circle?
Well, I'm not sure, Marcus. I don't think so. I mean, the continence mechanism, both in female and in male, I'm always repeating the same sentence, but it's not understood well. I mean, the female is, I think, more interesting compared to male, maybe because we face female urinary incontinence more common compared to male counterpart, because of the anatomical congenital weakness, the presence of vagina, etc. But it's very interesting. As we were discussing the surgery to the female urethra, for example, a urethra diverticulum surgery, a ureticulectomy, rarely leads to female urinary incontinence. All the female urethral stricture surgery rarely results in urinary incontinence, although you cut a significant amount of sphincter there, let's say sphincteric tissue there. So the sphincter in the female urethra appears to be the whole urethra itself, also counting on the intrinsic mechanism of the urethral mucosal, let's say, health and folding. So, but we still do not understand why we experience female urinary incontinence in some patients and some not, although they have the same anatomical or physical examination findings.
Absolutely. No, it's a very interesting observation. So, well, it's been a fantastic roundtable. Now, Tony, as a chair of the roundtable, are there any final messages that you would like to?
No, I mean, I appreciated the questions for the audience. I think all the individuals did well. But I think this was a complicated issue that we tried to keep it simple. I mean, for example, you talked about the urethra, and we didn't get into ejaculation, for example.
Yeah.
Like emission that's autonomic, then ejaculation is not. But that's another complexity. I think my sense of this, that this was successful, and I think we'll see that in the response. And I just think we should try to continue from this with further, roundtables in the future.
Yeah, that would be fantastic.
That's my sense of it. So.
Absolutely.
And I like the roundtable. I like that particularly because, one, the audience, there tends to be more of an audience than you might see in a workshop. And it flows very nice. Anyway, I thought it went very well, and I just want to thank everybody for participating.
Oh, thank you.
Well, Tony, Tufan, thank you very much indeed, and also, of course, Yoko, the fourth speaker for the ureter. So we had Roundtable 1, a very successful discussion about the fundamental scientific mechanisms of the urinary tract.